So type 2 endoleaks are generally benign, and we only consider treatment when the aneurysm grows more than 5 millimeters and they have a persistent type 2 endoleak. Type 2 endoleaks are complex and they tend to be difficult to fix, and that's mostly due to the multitude of inflow and outflow vessels as seen by the yellow arrows on the right. I believe the key to successful treatment is direct nidus access and glue or liquid embolic embolization. You can see at the bottom, the yellow arrow is pointing to the nidus in the venous phase CT scan. And on the right, you can see a translumbar angiogram with the needle in the nidus and the multiple inflow and outflow vessels. In order to identify these type 2 leaks, when you get postoperative CT scans for the follow-up after EVAR, you do need to get, in addition to non-contrast, both an arterial phase, which will rarely see the type 2 endoleak unless it's an extremely brisk one, and the venous phase, as is seen on the right, again, the yellow arrow pointing the nidus. It does take some delayed time for that to fill the aneurysm sac. I think translumbar access and glue embolization is a fairly easy procedure to learn if you don't do it. We tend to use this 3-tier catheter with a silicone outer sheath, a metal cannula, and needle. The patients are put in the prone position. Punctures are usually done on the left side, but sometimes on the right. If you focus at the image on the right, you can see the spine, the 12th rib, the iliac crest, and the puncture site is usually in that red circle. That's a handbreadth lateral to the spine between all of these structures. That will usually give you a window down toward the endoleak nidus. You use multiple anterior, posterior, and lateral views. You pick a spot or trajectory based on the landmarks of the graft, although this is much simplified with the Siemens iGuide software, which I will show you in a bit. You start at about a 45-degree angle. Sometimes you hit the spine, and then you direct the needle a little anterior. You eventually will feel a crunch when you go through the aneurysm sac wall. You take out the needle only, and hopefully you will get blood flow back. You do your angiographic confirmation. Once you know you're in, you go and prep the glue, and I will show you that also. I use about 3 to 5 cc's of cyanoacrylate glue, and I'll show you the mixture. And then slow removal of the catheter, injecting about 1/2 cc of glue in order to plug up the arteriotomy hole. When you hit the nidus, you should see some blood return, and sometimes it's more brisk than this, actual pulsatile, but you should get some return or you're not going to be in the nidus and not be able to successfully glue it. Injecting glue in the thrombus does not work. You perform your angiogram, and once you know you're in, you inject glue. These next few slides show a slow injection of glue into an endoleak nidus. You can see as the nidus starts to fill, so does the outflow vessel seen down here. And as you continue to inject glue, you see the outflow vessel start to fill and stop. The nidus fills more, and then you can see some of the inflow vessel here filling. I tend to use cyanoacrylate glue. I use other liquid embolic agents. The cyanoacrylate glue, I usually use about 2.5 cc's of oil to 1 cc of glue. This gives you about a 4-second polymerization rate for the glue to harden. You can alter that by adding more or less oil in order to make the polymerization rate shorter or longer. And this is, you would make it shorter if you worried about glue extending out, let's say through the IMA, you would use more oil and have a longer polymerization rate. If you had a diffuse type 2 and you actually wanted it to spread out more. But depending upon how much oil you use compared to the glue, you can change that. And we're usually somewhere between 2 cc's of glue to 3 cc's of glue. And most commonly it's 2.5, which gives you that 4-second polymerization rate. Here's a venous phase CT scan showing a type 2 leak. On the top left, you can see it hugging the stent graft and the beginning of the inferior mesenteric artery. As you come down, you see the inferior mesenteric artery filling and the endoleak hugging the stent graft. In the middle, there's a coronal view seeing the type 2 leak. This is the intraoperative translumbar angiogram of that patient. the angiogram mimics the CAT scan. You see one large outflow vessel. After the glue embolization, you see the nidus is completely filled. And if you look at the non-contrast postoperative CT scan, you see that where the nidus was is completely filled with glue, as is the very origin of the inferior mesenteric artery in the top right, and the glue hugging the graft as the nidus did. The iGuide system with the Siemens fluoroscopy unit, I believe there are others for the other units, but we have all Siemens here, will give you live needle guidance directly into the sac. I think it is extremely simplified and made the needle placement much more accurate. You first start with either a spin, as you would for fusion for an EVAR or FEVAR, or in the newer equipment, you can actually just do a PA and lateral. And then the techs will fuse the bony landmarks, as is seen here, from the preoperative CT scan to the fluoroscopy unit. Once this is done, you pick where you want to enter into the nidus and where you want to start on the skin. As is seen in this video, this green was where we picked we wanted to enter the aneurysm sac, and up on the left you can see we pick where we want to go in the skin, and it will give you a direct line path, making sure it's not going to bring you into the any structures that can be damaged by the needle. And you can see in multiple views here the path that we're ready to take. Once you do that, you will see something like this on your fluoroscopy unit screen, showing the multiple paths, and then you have live guidance on the fluoroscopy unit. It will show you in multiple views. Here's a lateral and obliques, showing you how easy it is to direct the needle along the path into the aneurysm sac, using the same principles as the needle access I showed you a few minutes ago. You then do your angiogram once you get your blood return, inject your glue, and here again you can see the glue filling the entire nidus. It can be used for right-sided access, although rare. In this particular patient, it would have been extremely difficult to come from the left side. You worry about the inferior vena cava here. It's a narrow window, but we did use the iGuide, which was able to negotiate or help us negotiate the needle right into the endoleak nidus. Here you can see the intraoperative glue filling the nidus, and the postoperative CT scan with the glue on the right, mimicking the preoperative venous phase CT on the left. We recently published our experience. It's in press in JVS. We don't have a publication date yet, but it's online. We looked at 30 consecutive patients that had good follow-up for after translumbar embolization for the type 2 leaks. Mean age was 74 years. The majority were men. The mean aneurysm size was 5.8 centimeters at type 2 endoleak discovery. And at 34 plus or minus 28 months, and there was a mean growth of 0.84 centimeters prior to the embolization, and mean follow-up was 19 months after the embolization. Half of the patients, 15 of them, the endoleak resolved and the sac stabilized. 11 of the remaining 15, or 37%, had a small type 2 endoleak. However, their aneurysm size and growth stabilized at a follow-up of just under 2 years. So these were watched. There were 4 patients that had a persistent endoleak and continued to grow. Of these, 3 of the 4 stabilized over 18 plus or minus 12 months. One, however, the 3 stabilized after a second translumbar embolization. One that had a second translumbar embolization continued to grow and ended up having an open ligation of the lumbar vessels. There were no embolic complications. Larger aneurysm size and the use of antiplatelet agents predicted persistent endoleak after translumbar embolization. Interestingly, the use of anticoagulation did not predict persistent endoleak after translumbar embolization. So in conclusion, translumbar embolization of type 2 endoleaks is safe and I think very easy to learn. I do think as long as you can identify a nidus, that it is the best way to treat type 2 endoleaks. And those on antiplatelet agents and with larger aneurysm size may require longer follow-up. And I thank you once again for your time.